Hi, and welcome back to the Pro PA podcast, where future pros in medicine are made. I'm Angie Urbina, your host for this dermatology series. Today we're diving into fixed drug eruption, a distinct type of cutaneous drug reaction. Fixed drug eruptions are unique in their presentation and recurrence, and while they're less common than other drug eruptions, understanding them is essential for primary care and exam prep. Let's break it down into the essentials. What causes fixed drug eruption, how it presents, and what you need to know about its management. Let's begin with the pathophysiology. Fixed drug eruptions are caused by a hypersensitivity reaction to specific drugs. Upon re-exposure to the offending agent, the reaction recurs at the same site, usually within hours. Hence the name fixed. Certain drugs are more commonly implicated, such as antibiotics like tetracyclines and sulfonamides, also NSAIDs, analgesics, and hypnotics. Fixed drug eruption typically presents with solitary, well-demarcated, round to oval, dusky red to brown or black macules that may evolve into edematous plaques, bullae, or erosions. It may occur anywhere on the body, but common sites include the lips, genitalia, perianal area, and extremities. Acute lesions usually develop 30 minutes to 8 hours after drug administration and resolve spontaneously in 7 to 10 days after discontinuing the medication. One more note is that lesions often resolve with post-inflammatory hyperpigmentation, which can oftentimes be a clue. The diagnosis of fixed drug eruption is primarily clinical, relying on a detailed history of drug exposure and the characteristic appearance of lesions. And if needed, a biopsy can confirm the diagnosis in cases with unusual clinical features. The management of fixed drug eruption begins with identifying and discontinuing the causative drug. Thereafter, it is mostly symptomatic. For non-eroded lesions, topical corticosteroids can reduce inflammation and promote healing. And for eroded lesions, a topical antimicrobial ointment can be applied to prevent secondary infections. Now, in the case that the presentation is widespread or generalized, a short course of systemic corticosteroids may be necessary. And from a preventative standpoint, it's very important to educate your patient on avoiding the triggering medication to keep this from happening again. Here are a few clinical pearls. Number 1. Remember, fixed drug eruption lesions recur at the same site within 30 minutes to 8 hours of re-exposure, so that quick recurrence is a key historical factor. Number 2 is the pigmentation clue. The post-inflammatory hyperpigmentation may be seen and is also a clue in diagnosis. And thirdly, common culprit medications. You want to keep an eye out for those common offenders like sulfonamides, NSAIDs, analgesics, tetracyclines, and hypnotics. All right, let's test ourselves with a couple of clinical questions. Question 1. A 45-year-old woman presents with a small rash on her left thigh. She reports that it reappears in the same spot every time she takes trimethoprim sulfamethoxazole. She is currently on day 2 of treatment for a UTI. She adds that the last time it happened, it healed on its own, but with a darker skin color. Examination reveals a solitary, well-demarcated, dusky red plaque. What is the best initial management? Is it A, systemic corticosteroids, B, discontinue trimethoprim sulfamethoxazole, C, antihistamines, or D, biopsy? I'll give you a couple of seconds. If you chose B, discontinue trimethoprim sulfamethoxazole, you are correct. The hallmark of fixed drug eruption is its recurrence at the same site with re-exposure to the offending drug. Discontinuing the drug is the first step in management. Question 2. A 40-year-old man presents with a rash on his forearm that started 2 days ago. He reports that a similar lesion appeared in the same spot a few months ago and resolved with dark pigmentation. He denies any contact with possible allergens, and the only medication he is taking is ibuprofen, which he started 2 days ago for an ankle sprain. Examination reveals a well-defined, round, dusky red plaque that is non-tender to palpation. Which of the following is the treatment of choice for this patient? Is it A, topical antifungal, B, topical corticosteroids, C, topical mupirocin, or D, systemic corticosteroids? If you chose B, topical corticosteroids, you are correct. Topical corticosteroids are effective for managing inflammation and promoting resolution in non-eroded lesions caused by fixed drug eruptions. Great job! Thank you for joining me for this episode of the Pro PA podcast. Fixed drug eruption may not be as common as other drug rashes, but recognizing its distinctive presentation and identifying the causative medication is essential for effective patient care and prevention of recurrence. Don't forget to review your patient's medication history thoroughly and educate them on avoiding triggers. Stay tuned for our next episode, and as always, this is the Pro PA podcast, where future pros in medicine are made. See you next time.